Welcome everyone to Oncology for the Inquisitive Mind, the podcast that aims to demystify and unravel some of the mysteries of medical oncology for trainees and experienced doctors and anyone with an interest. And Josh, I know at the end of our last episode we talked about interviewing a good friend of ours, Andrew, but then we had a brainwave and realised that it was actually Breast Cancer Awareness Month. And we have an absolutely fantastic guest who is in high demand, so I'm thrilled that we could snag a few hours of her time. She's done about 5 talks around Australia for the past week. But we have Dr Belinda Yeo, who is a senior medical oncologist at the Austin Hospital and Olivia Newton-John Cancer Research Institute in Melbourne. She is trained in Sydney and spent some time at the Royal Marsden Hospital in London and completed a master's degree at the University of London and the Institute of Cancer Research. She's also heavily involved in research at the VCCC and is, as I intimated just before, thoroughly involved in education and flies around the country, nay the world, giving talks and imparting her wisdom on breast cancer. So we're absolutely thrilled, Belinda, to have you. Thank you so much.
That's a very generous introduction. It's not that sexy, I'm sure, but thanks, Michael. Thanks, Josh, for having me.
And so we thought that, you know, we spend hours and we waste hours of people's time rabbiting on about one or two topics a day. But today we're going to do something different. It's basically going to be a pearls session, a picking of the brain of a very experienced oncologist who's seen it all and done it all. And so I guess, Belinda, we just wanted to ask you about your time as a clinical research fellow at the Marsden. It's getting to the current climate, I guess, is that people need to start looking for research opportunities, and the Marsden always comes up as a very prestigious place. But what was the train of events, I guess, that caused you to pursue some research at the Marsden?
Well, I guess like a lot of things, it's a bit of luck, and a lot of my career has been a bit of luck. So I knew I was very keen to travel and go overseas, and that might seem a bit mute now, but and I wanted to go somewhere where I could get hopefully really good at just one thing. I didn't really know what that one thing would be, though, I have to be frank. So I looked at a few fellow jobs, but like a lot of fellow jobs, you know, it's a lot about who introduces you. And you know, at that time I went over and, you know, met a few people, and it just had a great vibe. It really felt as though, I mean, obviously there's some extremely well experienced, you know, every paper you read, you know, the first or second author is someone who you were meeting, which was very inspiring. I guess the other thing is, from a medical system point of view, the NHS felt like a similar model that I would be working in when I came back to Australia. So yes, look, I have to be fair to you though. Look, mostly a lot of luck, you know, having a cup of tea with someone and, you know, rolling on from there.
I doubt you can just fall into a fellowship at the Marsden though. Yeah.
Well, I think you're right. You do have to put in a bit of work. I mean, time is one thing. You've got to really plan well ahead, and you might think you're going to go in 12 months and it takes a bit longer. And I think you also, I think talking to people who have, you know, been to some of these places, and it doesn't have to be overseas, but certainly that was, I mean, you know, London is also a great attraction. The city where these places are is often part of the charm. So talking to people who have been before, and I guess, you know, I mean, I was there for about 4.5 years, and I think the one thing, you know, I do say to our trainees going over is it does take you a little while for them to get to know you. You know, I'd been in kind of Sydney, you know, kind of done the training route as many of you have, and a lot of people know you and, you know, might think you're not too bad. But when you go to a new place, no one has a clue. You know, you might have a CV that looks okay. I don't think mine was flashed at all. But so it does take a little while just for people to trust you and you to get to know who's who. And I think that's why, especially, you know, I'm not sure when I went how long I thought I'd stay. I certainly didn't think I'd stay 4.5 years. But it was actually very hard to come home after all that. So yeah, no, I had a great time.
So I might ask the next question, because this is kind of our origin section of all our interviews, where we like to pick your brain of your motivation. The question I have, so, you know, you did your BPT, or for those, the basic physician training, and then you chose oncology. Before you decided to head down the research route, go to Marsden, you know, kind of explore that side of, I guess, your career, what made you choose oncology? What was the kindling to your passion?
So I think when I left school, I actually was turned away from medicine a little bit. I was from a medical family, and I thought maybe journalism would be a good gig, and so I did an arts degree, which was a lot of fun. Didn't get me a job, and certainly probably taught me that I'd be a terrible journalist. And so kind of medicine was like, in some ways something that I was a bit familiar with. And so that's kind of how I ended up doing medicine. In fact, it's kind of a funny story. When I did the GAMSAT, which I think of many people still say, I actually got somebody else's score. So when I got the result, I did really badly, and I was like, right, that's it. I'm clearly not meant to be a doctor. And then about, I don't know, several months later, they wrote back and said, oh no, sorry, we gave you someone else's mark. Would you like to come back for an interview? So anyway, but moving quite along from there, I guess, it was very obvious I would not do surgery. I faint in theatre. I'd faint before the patient even came into the room. So I wasn't really going down that path. I enjoyed problem solving, and I enjoyed a kind of a multidisciplinary approach. So I enjoy, having interaction with lots of different specialties. And oncology seemed like that. And at the time, and this probably sounds weird because all of the specialty programs have amazing research opportunities, but oncology really did seem to be the poster child back when I was doing BPT. So, and I even say this now, oftentimes, I mean, I think if you want to fix a lot of problems, oncology may not be the thing to do, but I think there's a lot you can do even when you can't perhaps, fix the cancer. And that's what I find really rewarding. And still, I mean, obviously I still have a lot to learn. So that was kind of my path, if that makes sense.
Yeah, no, that's actually fantastic, and thank you for sharing. I think just for our trainees, it's really great to put into context, because when you're at the start of your journey, or even before you start your journey, everything seems really daunting, and you hear the ongoing theme of it was a bit of luck. And I think the reality is most of medicine and where you end up is also a bit of luck, as opposed to just, you push headfirst into whatever you want and you're going to get there.
Yeah, I think that's true. I mean, also working out you work so hard as a registrar, and, working out the patients that you enjoy seeing, I think was something that was kind of obvious to me. So, I didn't get a lot of kick out of finding a heart murmur or, that kind of thing. So, and still don't. But, yeah, I mean, I do think you need to enjoy, particularly if you want to be a clinician, the patients that you'd be looking after and their families.
You mentioned that, and it's something that we've said as well, but it's very true, that oncology is not the best specialty if you want to fix things. But as far as oncological subspecialties go, breast cancer is probably where you get to do the most fixing. So where did this passion and focus for breast cancer come in? Because you mentioned when you went to the Royal Marsden, you weren't sure.
Yeah, so that. You know what? That is the job that got handed to me. So I mean, at the time, I got a job in Toronto, which was going to be a bit of a kind of pan-cancer phase 1 job, and the Marsden job was a breast job. And I remember leaving thinking, having met all these famous people and, feeling extremely small and thinking, do I really want to see predominantly, women, and often very well women, for the rest of my life? And it sounds a bit weird, but actually it's a real privilege. I really enjoy it. And you obviously look after a lot of men in that process, as family members and friends, and we do obviously have men with breast cancer. But that was the job that I got. So, there you go. And, I do remember at the other end of, that 4.5 years, even, my mentors there saying, you don't have to do breast cancer now, Belinda. You can go and do something else. And I thought, are you kidding? I've just spent all this time, trying to learn from you guys. So, yeah.
And so you finished your time at the Marsden, and I am going to assume you got a fair bit of research experience, learned from the best. You then ended up back in Australia, and you chose, well, I don't know if you chose, but you ended up in Melbourne, working at the Olivia Newton-John Centre and the prestigious Austin Hospital. Was it kind of a perchance you got the job and you ended up in a different state? Was it choice? How did that sort of land?
Well, I think like, all advanced trainees and fellows know, there's a lot of anxiety when you get towards the end and think, how am I going to get a job? And, you think, have I got to wait? Where will I work? And at the time, in fact, I was almost setting myself up to stay in London. I was pretty happy there. And there really wasn't a lot available in breast. And of course, jobs come up, and, I kept getting advice, come home and do something else. Oh, and you can do a bit of breast on the side. But I really decided that, this is what I wanted to do. And this job came up that had, this, I guess, blend of being able to work in a, big public hospital, being able to do some research, and in a city that, I really didn't know very well, but came back and visited a few times and thought, this, I'll give it a go. And of course, 6.5 years later, we're very much settled here. Yeah.
Yeah, fair enough. No, Melbourne's not a bad place to settle, I must say.
No,
As far as places go.
that's right. It's a pretty good city. Yeah.
So I think that, Josh, unless you have any other burning questions for Belinda as a potential pathway of a career pathway that people might want to imitate, we might just start picking your brains, Belinda, if it's all right, about breast cancer itself.
Go for it.
Which I mean, breast cancer has always been an area where there is a lot of research and a lot of, drug development, and we've said it before, a ton of really, really effective treatments, especially by the standards of, or if you compare it to things like lung cancer and what have you. But I guess both now and in your career, were there any particular avenues, not necessarily individual treatments, but sort of treatment modalities even, that really got you excited and made you think, oh, this is really going to change the game?
Yeah, I mean, that's a hard one to answer, because I think, one of the problems of breast cancer, if you like, it's a good problem to have, but as you mentioned, most people are cured from this disease. We find it early. Most people have small cancers that we treat, and many, I'm sure, we overtreat. And so it's this balance between really trying to ideally find those patients who have something to gain from what we have to offer them. And that's the nuance of breast cancer that I think is really tough. The patient who presents with very advanced disease, or, high grade, triple negative, lots of nodes, it's very kind of clear what pathway they have. But, as I'm sure you guys have experienced, that nuanced discussion between, is chemotherapy going to benefit you here? How intensive do we make the endocrine therapy? And, over the course of, the last 10 years, we can see that these are still questions. When I was training, everyone was like, who do you give chemo to? We're still asking that question, 15 years later. And I think, now we have more intensive endocrine therapy, which is good, but it's tough. And these are treatments we give for many years. Obviously, in the HER2 positive space, I mean, we've had fantastic drugs. We changed the face of HER2 positive breast cancer, and that continues just, year on year. And of course, the ADCs in that space, and perhaps actually across all of metastatic breast cancer, and perhaps even into the early setting, are an exciting space. Actually, not just for breast cancer, but, my colleagues tell me, these are changing the face of other cancers as well. So, I think it's interesting that, I always think of, we keep reminding people breast cancer is not one disease, it's 3, 4, 10, whatever you like. And we're almost coming back to saying, oh no, maybe everyone will benefit from this one drug. So, immunotherapy, I think, is a real frustration for breast cancer at the moment. I think I feel we're a long way behind our colleagues in being able to work out who benefits. And my hunch is that, if we're going to get immunotherapy, at least in Australia, in a funded sense, that we can use it routinely, it may in fact be in the early setting. And that will be the first time that I can remember for a long time where a drug, perhaps is used in the early setting before it's used in the metastatic setting routinely. I might be wrong about that. You can play this back to me later and see. Yeah, so they're just a couple of initial thoughts I had, Michael.
Yeah, and I wanted to focus on one of the things that you said, is that nuance, that grey. A lot of the studies that I'm familiar with, they have very obviously concrete inclusion criterias for, thinking about monarchy and abemaciclib in the adjuvant setting, which I know we've gone through recently. What is your thought when you're confronted with a more equivocal patient? Do you have, obviously, there's patient factors, patient preference, and it's a discussion, but do you have a focus or a thought process that you go through even before the patient comes in, where you sort of say, what am I going to recommend, assuming that the patient is sort of open for everything?
Yes, I do. I'm not sure I follow this every time, but I do. I mean, I think it is always good before you meet the patient to have a sense of what, you would recommend. And of course, our MDMs help us a lot there, so it's not one decision. The other thing I do, sometimes it is not clear, and many times the answer is not clear, as is in all of medicine. And I usually go back to that, well, if this was my sister, my mum or me, what would I do? And oftentimes, if you're really on the fence, that really helps, actually, gives you a lot of clarity. Then, of course, you've got to meet the patient, because you can be right on the fence and the patient walks in and it's abundantly clear what the answer to that would be. And that's what's so beautiful about meeting the patient. So oftentimes, when the, registrar comes in and says, I'm just about to see this patient, and, which is fine. And I think oftentimes we need that feedback, but I usually say, well, go back and meet them and then come back and I'm sure you'll know the answer. And that's how I work as well. I mean, our patients give us, a lot of information. Patients are pretty well versed in these therapies. I mean, look, chemotherapy absolutely still gets a very bad rap, and despite making it hopefully a bit more tolerable, it still is toxic. But I think people's experience of that, either with family or friends or what they've read, is often something that you may be able to, change their minds as such in that consultation, or if not in another one. So, but that's kind of how I think. So, have a preconceived idea of where you're heading. You've also got to be willing to maneuver that. And sometimes if, it might take you several visits, you might see someone and think, look, you know what, they're borderline. I really do want to get an echo. It's okay. I don't need to make this decision right now. But, MDMs have revolutionized this as well. I think they're a really good avenue to be able to hear different opinions, and I often get surprised how, we often don't agree. And I say to the patient, look, if there's saw 100 oncologists around Melbourne, 70% would say this, and the patient kind of looks at it and says, how come you don't all agree? But usually then I tell them, I say, well, look, if we don't all agree, it probably means that there's not a clear answer, and maybe the benefit of having one versus the other is, is marginal. And I do think sharing that kind of uncertainty with the patient sometimes is really important, because I think it helps with decision making.
Yeah, that's so true. Belinda, thank you for that. And I picked up on one point, and it actually is a good reflection. So when you say sometimes the people have not disagreements, but people have different opinions of which is the best treatment, there's no clear pathway to kind of manage. And you highlighted sort of bringing the person back for sort of second and third times. Let's say you've hypothetically got someone with an aggressive triple negative breast cancer where chemotherapy is definitely the right path, and they themselves are exclusively very reluctant. There's also sort of a lot of cultural pressures as well with certain ethnicities who don't want chemotherapy, as you said, the bad rap. What's your approach to, I guess, trying to convince some of these very, very young women who very apprehensive for good reason to kind of go ahead with, I guess, complex treatments that take up months of their lives, if not longer, have potential, long-term complications like peripheral neuropathy?
Yeah, so I think information is power. Making the good we don't always make the best decisions based just on information. But if I don't give good information that is, in the mode that the patient's going to understand, then I haven't done my job. And I also think giving my opinion is important. I never like to say to the patient, this is totally up to you, I'm not sure. So I always give them my hunch, if you like. And I guess the example you gave in triple negative with, a young person, certainly we know that there's benefit of chemotherapy. I think one thing we have up our sleeve in that example specifically, and I'll use it, is that, sometimes the fact that you can give the cancer treatment before their surgery in that neoadjuvant setting gives people the knowledge of whether this is working. I think adjuvant therapy is so hard. Patient says, how do you know it's working? I don't. It's just the test of time. So, that's something where, maybe we've got that extra little bit of persuasiveness to be able to say, look, try this and, let's see how we go. Because the reality is the vast majority of these actually do respond. I think you've also got to work out what are their biases towards, against this. And some of them will be very reasonable, a patient who says to me, look, my mum had triple negative breast cancer and she died. And, that's a very difficult thing to change someone's mind. And sometimes the answer for them is not to have it. But I guess, working out who else is, around them, who's their support network? Are they in the room? I mean, in COVID, we haven't let anyone in the room. So, hopefully, there's not many more times or eras where we need to do that. And, I guess really listening, using, your team, like the surgeons, using them and your breast care nurses. And, and sometimes the decision is not going to be your recommendation. I mean, it's not often, but we all have seen patients who say, what, no, not for me. And I think you have to respect that. So, but I do try my very hardest, and I don't always get that right, but you try and just share your sense of expectation of what the therapy would be, maybe there's some misconceptions about, how they're going to be. They're not going to be in bed every day. They're not going to end up in hospital, almost certainly, So, and occasionally that gets patients over the line.
Yeah, no, that's very true. And I think having that support network, especially in these situations, is fundamentally important. And medicine has truly realized that not having family or, those people makes any kind of treatment really challenging.
Yeah.
Yeah. And I guess when you're dealing with a patient, we've talked a lot about the early breast cancer setting, first meeting them, and that sort of stuff. But do you also have an approach? And I know that we see these sort of patients pretty much every day, especially when you're on wards. But do you have sort of an approach of when things aren't going how we would want? So in the advanced setting, I'm thinking of one recent mutual patient, Belinda, I'm sure you can think who, where things really aren't going well, and you think, you at least I have this conception that we have lines and lines and lines of therapy. We have lots of things that we can reach for, but sometimes circumstances conspire that those things are taken off the table. Do you have, a thought process of balancing risk versus benefit, toxicity, and I guess against a diminishing benefit the more advanced and heavily pretreated a patient is?
Yeah, yeah, and these are difficult in every part of oncology and breast cancer. We are privileged by, having that comment, oh, there are many lines here. For some patients, there aren't many lines at all. And I think, look, it does help to know your patient really well. And I know in the public setting, we often work as a team. Certainly we do, we're at the Austin. And so, the patient gets to know a whole lot of doctors. Sometimes that's great. Other times it's a real frustration for them. But, if this is a patient, for example, who's been on a CDK4/6 inhibitor, done, what we'd argue is really well, they might have been on therapy for 3 years, and then they move on to, and very quickly they're on chemo, and they kind of move through maybe 2 or 3 lines of chemo after that over a 12-month period. It's a really frustrating thing, for the patient. But, also what you're balancing in that is, are they sick from the cancer? Because oftentimes in metastatic disease, they're actually not sick from the cancer at all. And that's where you're balancing up the side effects of the therapy versus the benefit. Of course, we want to shrink the cancer, but we also want to make sure the patient can tolerate the therapy. And as lines go on, that balance becomes more and more fine. And patients they're experts now. Third line in, fourth line in. I mean, if they've had early treatment as well, these are experts. So, you've got to listen to the patient. If the patient says, I don't want to lose my hair, I don't want to die with no hair, you've got to respect that. And so I think that's quite different to, meeting your, patient for the first time who you're trying to talk about, adjuvant chemotherapy, for example, or neoadjuvant, as Josh just mentioned. Your job is to educate them, whereas I think a patient who's been through many lines of therapy, they're probably educating you more. Look, sites of disease matter. What I think, being honest about, there's a 20% chance of this chemo working, for example, and some people see those odds as great, and others will go, you can't be serious. And we all have risk benefit, profiles we add to our life, and patients do this as well. So I think, look, it's unfortunate that I work in a cancer stream where we do have a lot of therapies, but, we don't always get to use them all. And for the right reasons, treating someone, very close to death is sometimes desperately what they want. But you're not sure that that's always in their best interest. Being honest and, being able to share, again, it's a comment I made before, your uncertainty, I don't know whether this will work. And you look back at their prior therapy. If they've had really good responses to other lines of chemo, yeah, that's fantastic. If they've been resistant and you have just chopped through, 3 lines very quickly, your expectation of a further response is pretty low, unless you're really trying something very novel or you're sending them for a clinical trial. I don't think I answered that terribly well, Michael. Look, I think it's tough. Probably you can see from my answer, I think it's really tough.
Yeah, absolutely. And especially if, as you say, they're experts, they might also might have expectations.
Yep.
And so a big part of it might be them actually asking you, which is something that I haven't actually experienced, why can't I have treatment X that I've seen on the internet? And it's very easy for HER2 negative patient who's asking you, why can't I have TDXD? Well, it's obvious. But if you have to be a little bit more, you have to, I guess, explain it a little bit better if it's not that obvious.
Yeah, absolutely. And, I mean, thanks to, the community support for breast cancer out there, patients do often come and say, I saw on the news, X drug, and the frustrating thing, it may work, but it may not be available. It may be completely irrelevant because it's a different type of breast cancer. Or you might be like, oh my goodness, I don't even know what they're talking about, or it's some phase 1 data that they saw on the news and you're thinking, gee, I don't even know. So I think I think you do have to give them the time. And even if it's a completely irrelevant drug for them, you need to walk them through why that might be, so that they don't feel as though they've just been, dismissed. So, yeah.
That's all. That's great. And I think there's a couple of points that I love that you just mentioned, Belinda. One of the things is patients that progress through multiple lines of therapy, and the other being, I guess, the toxicity profile of these treatments. What do you find from a training pearl perspective and a bit of an education point? Just from a basic chemotherapy management in, we can say early breast cancer, but any sort of breast cancer, what's the biggest toxicity that you find difficult to manage?
Well, I think I'll start with an easy one and I'll perhaps go to some others. So I think, look, we use a lot of taxanes in early breast cancer, and peripheral neuropathy is extremely common. And we don't seem to be very good at knowing who gets it. I mean, certainly if you've got, comorbidities that suggest you're at risk for it, but, very few of our patients do, and yet still up to 30% of patients get this. And of course, the problem of peripheral neuropathy is it can be permanent, so you might cure their breast cancer, but leave them with a permanent neuropathy. So that's something that, we have been far more willing to truncate, give weeks off, maybe dose reduce. I mean, obviously we want to keep up dose intensity in the curative setting, but you do have to balance that with a potential permanent toxicity. And if you're out at, week 10, 11 and 12 of paclitaxel, and your patient's dropping things, I think very hard about whether or not it is worth giving those few extra doses. And again, if you're giving it in the neoadjuvant setting, you hopefully have some response information already, which might help drive that decision. I think there are other, probably maybe not where you were heading here, Josh, but weight gain is a big one. Weight gain is terrible for patients with breast cancer. Many of our patients are already overweight. It's a risk factor for breast cancer. It's in Australian society. And patients who, we're really keen to get them exercising from the day of their start, or even before they start. We're trying to get them to eat well, but it is hard to lose weight or to even maintain your weight on chemo. The steroids are there. And certainly for our young women who are making, at least if not permanently, but temporarily menopausal, I think weight gain is a really, really tough one. There are many things about being on chemo, losing your hair, and scalp cooling's great, doesn't work for everybody, and not everyone can tolerate it. But I think weight gain's just one of those ones that I think, particularly for this population of patients that we're treating, is a tough one. And it's just so much harder to get off. So oftentimes in that first consult, you've got so much to talk about that these are the things that don't really come up. It's more, this might affect your heart, although the risk is very low. Febrile neutropenia. Although again, in breast cancer, the risk of coming into hospital with FN now is really low, thank goodness, because we're getting better at giving these drugs and we've got more supportive therapies. So they're probably some of the things. I mean, really late effects, permanent menopause for patients, effects on fertility. These are obviously, really important for young women. And I think just as a general comment about, treating, I say older ladies, I mean, 65 is not old, but, there is data now where we do want to think very hard about, do they need this anthracycline? Because if they're, over 65, if they've got hypertension or high cholesterol or family history, they're automatically in a category where that risk of, affecting their heart and their future cardiac health is significant. So that's something that, I do spend a bit of time on.
You segued pretty much perfectly into my question there, Belinda, with the note about the heart. It's something that is really harped on about in for us all the way back to BPTs. It was a BPT question our year. The anthracycline, stereotypically, the toxicity is irreversible, but I guess the other drugs that are very commonly used that can cause ejection fraction issues are the anti-HER2 drugs, trastuzumab and its derivatives. And this is something that I guess I think Josh agrees that we really haven't had a consensus. It's one of those, you ask 3 oncologists, you'll get 3 different answers in terms of monitoring, and I guess when to be worried, what to do about it. Monitoring is one thing, but I guess that leads to the logical question of what you do about it if you, especially if it's a young person, you do a repeat echo or a gated blood pool scan and you notice their ejection fraction has dropped significantly. Do you have any wisdom about that?
Yeah, so I mean, fortunately, one thing, we have a lot of people to help. So in fact, my PhD student is a cardio oncologist or an onco-cardiologist. She's actually a cardiologist. And actually there's going to be, far more support, I hope, in the future. We'll set up clinics if you haven't got them at your hospitals already for this kind of issue. Because of course, IO brings cardiac issues. I think, for that particular example you bring, HER2 positive patients whose EF drops on treatment. Firstly, you've got to look at, are we going from a super therapeutic EF to a therapeutic EF? They're going from 75% to 65%, or, were they borderline to begin with, maybe at 55% and then dropping under? That's far more significant in my eyes. Certainly, I do tend to repeat with an echo. So if they've had a gated heart pull scan, I'd send them off for an echo just to see whether I can maneuver that number at all. Again, look at where they are in their HER2 therapy. Look at what their risk is of this breast cancer, because as you guys know, the data for 6 months versus 12 months of trastuzumab, there's a bunch of studies, some are equivocal, some are a little bit better with the 12 months, some look about the same. And if you've got a patient who you started treating and, their outcome from this breast cancer is going to be brilliant, and they're getting, certainly if they're past 6 months, then you may at least decide to hold the trastuzumab and potentially stop it permanently. Interesting though, when you look at the data, we don't stop it very much. We often try and push through and just monitor. And if you're worried about it, you should be monitoring more often. So we might do a kind of mid scan at 6 weeks instead of the 3 months. And then, of course, we can utilize our agents like the ACE inhibitors and potentially beta blockers. And once I start to do that, I usually call my cardiology friend and say, do you mind seeing this patient, and they're really interested in it. I mean, I think this is it's kind of a branch out of cardiology that is getting a lot of people interested, because they're seeing these patients, 10 years later coming in for their, their caths and saying, oh, Belinda gave you chemo 10 years ago. Oh, but she doesn't see you anymore. So, yeah, you do have to watch it. I mean, your heart's a pretty important organ.
Yes, slightly. Just out of interest, what's the biggest drop in LVEF you've seen in the therapeutic setting? Obviously, in the HER2 setting.
Oh, look,
is there one that sticks out?
I mean, I've seen someone go down to kind of 20%, and and actually it was someone who actually had no comorbidities at all and was fairly young, and excuse the pun, but your heart sinks. So fortunately, most of these are reversible. Yeah, that was certainly a big surprise, because most of the patients I say, look, we monitor it, but your heart's going to be fine.
We love puns on this show, so the more the merrier, really. We did one last week on early gastric cancer. We're talking about cross, and I quite enjoyed using cross in every second sentence.
I think Josh got about 20 uses of cross puns,
and they were all terrible.
Okay.
Speaking of LVEF, we actually have a patient at the moment, very similar situation. The young, no comorbidities, the left ventricular ejection fractions continuously kind of sliding, and it's a very early breast cancer and it's HER2, so we've kind of got that cardiology involvement, so it's good to see even across sites it's quite similar. Branching, I guess, also maybe in the HER2 metastatic setting, and this might be a little bit of talk about liquid biopsies and rebiopsying. I saw in some of your research, I was going through a little bit of your research, but I can't say I understood everything that I saw, but there was one publication which you were part of, which was talking about intratumoral heterogeneity as a driver of breast cancer progression. And I think this is a really fascinating area personally. And looking at, I guess my question is this: you've got a patient with, let's say it's a early HER2 positive breast cancer, maybe it's a metastatic HER2 positive breast cancer, and they're not responding the way you want. When do you consider, hey, do we need to rebiopsy this person? Because is there a potential that maybe the histology's changed, maybe they've transformed into a triple negative breast cancer, maybe there's something that's been missed. What's your, I guess, your directive to kind of say, okay, we need to kind of keep digging?
Yeah, I mean, we see this often. We see it not too often in the early setting, and we certainly do see it routinely in the metastatic setting. So we can perhaps deal with them slightly differently. But I guess one key thing is if you've got the opportunity to watch a cancer shrink or not or grow, so in that neoadjuvant setting, you just absolutely have to repeat the receptors from on your excision. And obviously, if you're not winning in the neoadjuvant space, then you may do a repeat biopsy because, of course, you've based your neoadjuvant decision and perhaps a couple of cores that said to you this is a luminal B breast cancer or a triple negative, or in your example a HER2 positive. I mean, it's interesting, the HER2 amplified breast cancers are pretty consistent, so you can do any of these things in the metastatic setting, and even as you progress through the metastatic setting you can lose HER2, gain HER2, obviously lose ER, but probably the most common thing we see is losing ER. So in a series we looked at of ours, about a quarter of our patients changed their subtype across their metastatic story, whether that was at relapse or during the course of their progression on second, third, fourth line therapy. So we are very keen, as to biopsy patients to get that information. I mean, you can get that information from a liquid biopsy, but at the moment that's not really routine care, and it's certainly the turnaround for that is usually, at the moment at least, not enough to be able to inform your very next decision. So always think about it, and especially if you've got a patient who you might see responding. We say, oh, if the drug works, it works everywhere, and then of course you use a drug and it's working well in the liver but not in the bone. I think it's often worthwhile really thinking about that, because we know that there's a lot of heterogeneity in breast cancer, both obviously across patients, but within patients as well. And sometimes that doesn't matter. I mean, if it's heterogeneous but it responds to taxane, then fine. But if you're relying on just a HER2 therapy and that the cancers, there are going to be HER2 negative and HER2 positive cells there, then you're going to need something else than just HER2 directed therapy. And I do wonder whether the genomic assays, something like the PAM50, I mean, we don't even have these at the moment, at least, although that might be changing in the early setting for luminal disease. But it might be something that we can use in the metastatic setting to be able to better inform our therapies, because just because something's HER2 positive doesn't necessarily mean it's HER2 driven. And likewise, just because it's ER positive, it may in fact behave more like a triple negative. And I think we've seen that from work from many smarter people than me in publications in the last 10 years.
You mentioned very briefly the genomic testing and I guess some of the risk stratification tools that we have. And for me personally, it's still quite confusing about using things like Oncotype DX in the early setting. And I think you've told me after a clinic, you'll inevitably do these because you're not sure, and then you'll get an intermediate risk result because the test effectively isn't sure. But where do you see these sorts of risk stratification tools being used in do you think they're going to become a more common part of our practice, or do you think there's really no substitute for a clinician's intuition?
So, look, speaking currently, as of today in Australia, we don't have funded access to these. So there's many of them out there, and you'll know them: Oncotypes 1, EndoPredict, Prosigna, MammaPrint. These are all genomic assays taking a section of the tumour, mushing it up, and looking at a bunch of genes to work out, did what your pathologist tell you marry with when you mash the genes up and look at estrogen regulated signals and particularly proliferation? And Oncotype is driven basically by those two things. Do you get a different risk stratification result that would change your initial recommendation? That's really the predominant way we use these, and we have come a long way. So, with data from studies like TAILOR-X, the truth is, most node negative patients don't need chemotherapy. Some do, most don't. I think there's some ambiguity about young women still, although the question is, did endocrine therapy need to be tamoxifen, or should we have given them something stronger? Certainly, at least in our exponder, we've seen in a node positive cohort for patients with that lower risk disease based on recurrence score, you can also get away without giving chemotherapy. And of course, the younger patients, the message from our exponder was everybody needs it. My belief is not every premenopausal woman needs chemotherapy. I just think we need better tests. We need better predictive tests These are predominantly prognostic tests. So where we are limited in Australia at the moment, I think if I'm doing this podcast, in 6 months, maybe it'll change, is they're not funded. So you've got to be judicious with using them. And I always say to patients, and this will not change even if we do get them funded, is you've always got to give them a recommendation if you didn't do the test. You've got to, because they're not available to everyone, and they are just another piece of information. I mean, I think just because they're worth, 3, 4, 5 grand, sometimes the bit of information that they give is not really going to be any better than putting together the tumor size, grade, nodal status, patient's comorbidities, and that discussion. So you do need to use them in conjunction with all the other information that you've got and a really good pathologist. And of course, if they're funded, we will use them more. There is no doubt about it. We've seen that in the UK. We've seen it in the US, because, a huge passion of mine is sparing patients treatment that they don't need. And if these can do it, then we probably should use it more. And certainly, if you give a lot of chemotherapy to ER-positive disease, then you probably should be using these more, because they will definitely reduce your chemotherapy prescribing. So I think what I would say about the test, though, is that, I spent many of my time in London developing one as well, which you wouldn't be surprised is not commercially available. But it does make you realise that they are just a bunch of genes put together with a certain algorithm. And sometimes they are very, very driven by one thing or very, very driven by another. And when you don't know what's in that black box, we almost trust it more. And I think cost has a lot to do with that. So, you do have to know why you're ordering the test. Probably as the best example for where we are in Australia is, when would I use them at the moment, or when do I use them? I use them when it's going to change the decision. And that might be, I am truly on the fence and the patient at this stage can afford it. And I think, that extra bit of information probably will tip us over one way or the other. But actually, probably more times I use it is when the patient comes in and says, okay, I understand your recommendation, but is there any chance that this could be changed, And that's probably where I use it, in fact, more. We're trying to, I guess, align our ideas about where to go. So that's probably at this stage where I use the most. But look, as the data comes out, I think as we get, perhaps even more sophisticated, tests, hopefully not too expensive, I suspect we will be using these, and I say generically more. And in fact, I actually think they have a role in HER2-positive disease as well. But, certainly we're a long way from being able to offer them to patients in that setting.
That's a great explanation, Mikey. And that was the thing I also get quite confused of, because I think it's always really difficult to, when you've got a patient being like, look, you don't need chemo, and I think putting in context of using it with lots of all your other clinical findings, other findings is super important. One of the, you highlighted, Belinda, you just give all these pearls when you're kind of explaining to our next questions. I really love that. One of the things you were talking about is, ovarian suppression. You mentioned it briefly, and kind of using hormone therapy, like whether that be tamoxifen, should they have tamoxifen, or whatever it is. I guess there's still a fair bit of debate and discussion on how long and how extensive you give ovarian how long you give endocrine therapy, and then there's another question about the ovarian suppression and that of toxicities. One of the things I struggled with when I started is, and I know it's silly, yes, premenopausal tamoxifen, postmenopausal you give a aromatase inhibitor, you've got variations of the theme. But would you mind talking just about your rationale, sort of when you'd give ovarian suppression, when you'd switch, kind of what things you look for? Because I think that's another quite a complex area of breast cancer management, especially for the beginner.
Yeah, well, I can tell you it's still complex for me.
Okay, good.
So I guess the way I think of endocrine therapy, and we might just for simplicity split out pre and postmenopausal women. So I'll deal with postmenopausal first. I think it's maybe a little easier. So we've got a plethora of drugs here. You can use aromatase inhibitors, and you can also use tamoxifen. Tamoxifen works across the, milieu of the whether you're pre, peri, or postmenopausal. So I go back to what's the risk of this breast cancer coming back? Why am I selecting an AI over tamoxifen for postmenopausal women? We know there's a, what we quote this magic 3% absolute benefit, potentially no overall survival benefit. So I really look at, is this a low-risk breast cancer? Then I think the difference between those two agents is pretty negligible. And then you're talking about which toxicities matter to the patient. If you're an intermediate or high-risk patient, and particularly if you've got a lobular breast cancer, then I will move towards really trying to encourage an AI. And I think being able to use bisphosphonates for postmenopausal women, makes me relax a bit, because then we can protect their bones. And of course, we know that it does have some protective recurrence factor too. So that's postmenopausal women. Premenopausal women, and in fact perimenopausal women, are really tricky. So I guess when we think of ovarian function suppression, if we take away the use of gazerolin with chemotherapy for ovarian function protection to preserve fertility, because that's one time when we use it during chemo. But if we're really talking about what's the role of it being able to improve their survival, in a high-risk premenopausal patient, I will offer them ovarian function suppression. Oftentimes, these patients have had chemotherapy because they're high risk. But I will ask them to continue it, and then I would elect, if they can tolerate it, to add an aromatase inhibitor in. But I think using tamoxifen and gazerolin is also a reasonable alternative. I think we've talked a lot about chemotherapy today, but I think chemo goes for 6 months and you're done. This stuff goes for years. So whilst we can talk about, I give OFS and an AI to all my high-risk young women, how many of them actually can stay on it? Because the endocrine therapy that you want them to be on is the one that they actually take. It's actually no use for me to prescribe it if they can't actually take it. So I think the first few years is the most important. If you can get a patient in that high-risk early setting who are premenopausal through a couple of years of OFS and AI, then if you need to back off the toxicity, I think you have achieved something in that first few years. And I'll be really interested to look at the soft data for patients who needed to come off their OFS and AI early because of toxicity. Because I think if you've got profound estrogen suppression for a few years and your cancer is addicted to estrogen, like, that should be enough, shouldn't it? Surely if the cells haven't seen estrogen for a few years, they'd have to be pretty stubborn, and maybe, endocrine resistant cells to be the one that survives. So having said that, sure, it's easy for me to say 5 years is the go, but it's tough. 5 years is tough. And if fertility is an issue for our young women, not everyone has 5 years to wait to be able to then decide, I want to get pregnant after you've, treated me and told me I'm going to be, likely cured from this breast cancer. So that's the other factor that I do keep in mind. Where OFS comes a bit harder is if you're treating someone, say, in their mid-40s, and you've given them chemotherapy because you feel that's appropriate. And then you're looking at, all right, well, if they're high risk enough for chemotherapy, you probably want to give them the best endocrine therapy. I think it's always hard, because if someone's getting now closer to that magical 50, maybe they're 46, 47, 48, and you've given them chemotherapy, the likelihood that you've rendered them menopausal is pretty high. And so OFS is not going to do anything there. And yet, of course, at the same time, we all get nervous about giving an AI to that 48-year-old lady who had chemo without being able to know for sure that her ovaries are switched off. So I think that's a bit of a harder one. And using a switch strategy is something that we do often use. So we might start with TAM, and once we're convinced they're permanently menopausal, switch them over to an AI. There are some women where you just will want to get the AI in early. And so you might use OFS. But, you're looking at these ladies, unless they have their ovaries out, for having these injections once a month with the GP, for years. And, that can be quite tricky. I don't know whether that helps. I think it's difficult. I think you've got to think of risk. You've got to think of what the patient's wishes are. What's their trajectory for this? And, you've got to keep bringing them back, because year one might go fine, and then year two, everything starts to fall apart.
Yeah, that's really true. I think also the quality of life aspect of going to your GP once a month in your 40s, and you might have young kids and got a full-time job, it all kind of, it impacts. It's a risk balance equation. So that's really quite interesting. That's a good take.
And those Zoladex injections, this is something that I only realized when I saw one of them. Like, they can be quite nasty. I just conceptualized it as like an insulin injection, one of those tiny needles, but it's the pellet and the massive needle, and doing that once a month it's quite hard.
I think you have to word up your patient when you start this and say, we're going to put you on this injection that's going to protect. I usually say, look, it's a bit more like an implant. It's not like, especially if they've had GCSF and they know what that's like. I'm like, no, it's a bit of a bigger deal. And in fact, over COVID, I had quite a few patients doing it themselves. I was like, that's
Oh,
pretty good.
wow.
I'm not sure I'd give myself gazerolin, but yeah.
Yeah. From one, I mean, very difficult, I guess, consideration to another. And again, you mentioned it, Belinda. It's almost like you've read our list of questions. But the question of fertility preservation, obviously, you know, the absolute heart sink patients are the really, really young women in their 20s, the triple negs, that sort of thing. And the women who you really have no choice but to give obviously very cytotoxic, but also very ovarian toxic chemotherapies, and obviously other therapies. What is your approach to, I guess, the balance of long-term outcomes and giving these women, I guess, a chance to even have children in terms of survival versus sort of taking away or permanently damaging their ovaries, and what strategies do you have? I mean, we know about OFS and how shutting down the ovaries theoretically protects and preserves the fertility, but do you have strategies on, I guess, how to better manage or how to and have that conversation with these women?
Yeah, it's tough. And I think, again, that first visit, there's a lot to go through, but you cannot shy away from this discussion at that first visit. So, let's argue we need chemotherapy here. So, and it's right, the gazerolin does offer some form of ovarian function suppression and protection, I should say. And if you're treating someone in their 20s or early 30s, you've got a pretty good chance actually that they're going to be able to recover, and their periods will resume at some stage when you stop all their endocrine therapy should they need it. That's actually quite different if you're treating someone in their late 30s, who may just as desperately want kids, may in fact have just been at the time when they were looking into this. Maybe they've even started the IVF type thing, and then sure enough they get a breast cancer. And we know that actually the risk of resumption of menses treating someone around the age of 40 substantially goes up with that risk of permanent menopause. So I think the age of the patient is really key to try and help inform them what the chances are of this working to be able to protect their ovaries. And a really important thing here, and it's always tough because patients diagnosed with breast cancer, I'm talking about chemotherapy, and then I want to send them off to a fertility specialist, and I want to do it ASAP. I mean, I had this situation just yesterday. And because you're on one side saying we want to start treatment really soon, especially if it was this kind of triple negative early setting, the cancer's in there. And yet I want you to go off and, bank some embryos or eggs, because I don't know how you're going to feel in 2, 3, 4 years' time. And if a patient's even remotely interested in that discussion, even if they come away from seeing the fertility specialist and say, you know what, it's not for me, I didn't need to do it. You can't go back. You can't come back 5 years later and say, do you know what, I wish we'd done it. And I've certainly had patients who swear, it's quite interesting actually. I've had both cases where patients, fertility's been really important. We've done that, and yet actually they've never used them for whatever reason. They've not needed to, or they've not wanted to. And of course, I've had the flip patient who says to me, I've got 2 kids. No way, Jose, I'm interested in that. Sure enough, 5 years later, they come back with their 3rd child and say, oh, look at this. So I think, we don't always know. It's a really stressful time to be diagnosed with breast cancer when you're young. But if you don't have that conversation, you're doing your patient a disservice.
Yeah, it's yeah. There's no turning back time, is there, with these big decisions in life? One other, I guess, aspect of breast cancer that we haven't touched on today is the BRCA testing mutations. BRCA testing, the mutations, the implication it has to treatment, and also, I guess, future planning when it comes to mastectomies and oophorectomies. Linda, would you mind sort of chatting a bit about that and sort of your kind of, I guess, outlook on BRCA mutation testing?
Yeah, so germline testing, and I guess now we do an extended panel. So the vast majority of the germline breast cancer is BRCA1 and BRCA2, but there's other genes in there that we're now learning are becoming important, and PALB2 is one of them. And so we still test in terms of a funded test. So being able to offer a patient to say, go and have this, you will not be charged, at about a 10% threshold. So if they've got a 10% or greater risk based on age, tumour type, family history, they'll get funded BRCA panel testing. It takes maybe, depending on your institution, somewhere between 6 and 8 weeks. And it potentially has an impact on not only treatment, because it may involve giving different drugs or additional drugs, But obviously, it has implications for the risk of further breast cancers and other cancers. I think where we've come, and this is definitely in my training lifetime, no one ever paid for a test when I was going through, because it was $3,000. Now it's about $450. And, I certainly think, hopefully, again, you can play me this back in 5 years, that, we're getting close to where this will be routine. So you get diagnosed with breast cancer and you also get offered germline testing. It will be funded, because I think the more you look, the more we will find. We describe, germline breast cancer being only really about 5% of breast cancer. But we know from data from the States and elsewhere that if you test everyone, that number goes up. So I do hope that this is something that, we'll be able to offer more women. It also, a negative test, we focus on the positive test, what are you going to do if it's positive? But a negative test is actually, it's quite a reassuring thing. Now, that doesn't always take away risk. If you've got a really strong family history with a negative BRCA panel, I usually say, well, there's clearly something in that gene pool. I just can't tell you what it is. The vast majority of our tests do come back negative, but I think it still is important to think about them. And the one thing I would say to you is that, again, there's a lot to do in that first appointment. You really need a few of these, but if you are going to do it, you need to do it early, because you don't want to be at the point where the patient's about to go for surgery, having had neoadjuvant, and yet someone's, still waiting for this BRCA test. Because you may think the risk is less than 10%. They may have paid for the test, but you will find some of those patients will turn out positive. We've all had that situation where I said, look, I don't think you've got one, and you do. So if you actually do go ahead with the test, try and get it done as early as possible, so that it can make, you can make the right decisions about surgery. You can make the right decisions about radiotherapy, for example. So I truly do think, though, Josh, is that, with time, this will become more and more standard. I'm not saying necessarily we're going to do bigger and bigger panels, but I just think we'll be doing it a lot more often.
Might become like the EGFR and ALK and ROS testing we do in lung cancer, where it's just sort of, it's a lung cancer, let's send it off for EGFR. It's a breast cancer, let's send it off for BRCA and PALB2. Belinda, we've taken up a lot of your time, so I will only ask one last question. And if you had the ability to communicate and talk with yourself when you started oncology, when you before you went to the Marsden, before you came to Melbourne, this strange and wonderful place, what if you could say one thing, if you could give yourself one little tidbit of advice, and I'm putting you on the spot here, but what would that be?
I think one thing about oncology, and this, I'm still learning this, is it's a pretty weird thing to do every day. And I think you've got to be pretty kind to yourself. Like, and medicine is anyway, when we compare ourselves to our family or friends who have these careers where they go into the city and they, work very hard, no doubt, but they go out for lunch and they go home and then the weekends off. Medicine's never fitted that. And there's a reason, I guess, why none of that might have bothered us. But then you go into a setting like oncology where, you're not curing a lot of patients in some of these cancers. And even in breast cancer, you're often dealing with young women, you're often dealing with these complex issues like fertility. And, even in older ladies who die from metastatic breast cancer, that's a death that we would not have wanted to have. So I think you've got to be kind to yourself. And, I think the patients who get to me are not always the ones that I think, like sometimes I fall apart with someone who you would have thought, oh, why'd you get so upset about that? So I think you just have to have that little extra bit of, I don't know, kind of self-awareness and, have people around you, be the professional, friends, family, whatever it is, pets, hobbies, reading, something that allows you to just go there and realize that it's not easy. It's not easy. I think actually Olivia Newton-John, I think dying, was really interesting. I found that, the day we found out she died, and I walked into work and there's all these flowers at the front of the hospital, which is beautiful. And then I'm looking up at our ward thinking, there's patients who we look after who die every day here, and there's no flowers at the front of the hospital. And I'm not saying it was inappropriate. It was appropriate, but I think we do some pretty strange things, pretty rewarding things, but you do have to look after yourself. And my mentors tell me that, and I don't always do it very well, but we get a lot of support from each other, and that's why it's a great team career, because there's a lot of people around you who are feeling the same.
Belinda, that's very very true about looking after yourself. What's your one when you look at yourself and you try to reduce the risk of burnout, what's the one thing that you do that kind of gives you that grounding to go into work every day and deal with such a complex, although rewarding, but complex, I guess, specialty and profession?
So my life is pretty simple. That helps. The other thing I've done in my career that I would not have done as a registrar advanced trainee, I wanted everything. I wanted everything instantly, all at once. And I think probably through the patience of my husband, I have, kind of learnt that, not trying to achieve everything at once, being able to just give yourself some time to balance out how much research do you want to do? Do you want to do some private? You don't have to have it all worked out in the first few years of your consultant career. And, looking after some precious time, if you can, weekends, planning holidays. These are the things that for me, my family's, really important. And I have a bunch of friends that have absolutely no interest in medicine at all. And that is incredibly rewarding. So, yeah.
Yeah, that's really, really, really wise words. So we don't need to know everything we want to do with our lives right this second. Belinda, I think from Michael and I, we just want to say thank you so very much for coming on our podcast today. I feel like it's been a mini condensed tutorial for someone with so much experience, and not just medicine, but world experience and life experience, to give us a understanding that these things do take time to learn, and we're building on our knowledge base. But you've been just incredible, and thank you so much for coming on our podcast.
Oh, well, thanks for having me. That was actually quite a lot of fun. And you got to remember, we learn from you guys too. Michael and I are on at the moment, and Michael tells me things I didn't know at all, both in and outside of medicine. So, that's why we work in the places that we do, because, we learn a lot from everyone. So thanks for having me, and good luck for the rest of them.
Thank you so much, Belinda. I appreciate it. Absolute tour de force.
All right. And on our episode coming up next, we will be talking about ovarian cancer. And for anyone who wants to know what Michael's, interesting facts are, they're called Michael's, Michael, what do I always say? Michael's fun facts.
Michael's fun facts.
He has a million of them, so it's fantastic.
And we look forward to seeing you then. Goodbye.
Bye.